From the campus of Stanford University.
People are worried about data. They're worried about their privacy and their security. They should be. We need secure systems.
This is the future of everything.
But we can't have a system that closes that data off. It is too rich of a source of inspiration, innovation, and discovery for new things in medicine.
With your host, Russ Altman.
Today on The Future of Everything, the future of artificial intelligence in medicine. Now, the availability of health-related data about all of us has exploded in the last decade or so. For a variety of reasons, there was a big push from the federal government to install medical records, and now they're highly present all across the country. And in that electronic medical record, your care providers list what they did to you, what orders they made, what diagnoses and procedures they made, and they even write notes about why they did it and what they're thinking. In addition, there's been an explosion in genomics, and we're beginning to see, not as advanced as the electronic medical record, but we're beginning to see people getting their DNA sequenced or other measurements of their physiology that's incredibly personal and gives information at a very high level of precision about the physiology of the patient. And then, of course, we have this third source, which is mobile sensing data. Some of us wear Fitbits or Apple Watches or whatever devices. There are environmental sensors in some workplaces. And so we're increasingly able to gather these data, which are health relevant, not always available to your physician, but someday they might be. But together, if you think about these three sources, the medical record, the molecular measurements, the mobile sensing, these provide great amounts of data relevant to your health. But a huge amount of data potentially and real questions about the utility, how to use it, and what to use it for. At the same time, many of us have heard about the big data revolution and artificial intelligence or machine learning, where we can create algorithms that take these data, these medical data or other data, find patterns in it, and then be able to make predictions that are useful, hopefully, for either a business or, in the case we're talking here, about healthcare. One of the hopes, of course, is that we'll use these data to improve care and maybe reduce costs. Now, how would we do that? Can we use these data, and plus the algorithms for machine learning and artificial intelligence, to assess the risk that you're going to have a disease so you can maybe make some lifestyle changes to reduce the chances of that? Or can we prevent the disease? Or can we give you an early heads up that this disease is very likely and you might want to make some changes in your job or where you live or in your planning? Can we diagnose disease better? Will we more quickly and sensitively decide you have heart disease, you have diabetes, and then get you into the medical system and treated? And finally, treatments. Can we invent or discover new medications or new combinations of medications that might more effectively treat disease? Well, Nigam Shah is a professor of medicine and of biomedical data science at Stanford University, and he's an expert at using medical data to discover new ways to assess risk, make diagnoses, evaluate treatments. Nigam, you recently published some work in which you used artificial intelligence to predict the likelihood that patients would die in the next several months as part of an initiative to consider the use of potential palliative care for those patients. How well does your model work, and how well has it been accepted by physicians and patients?
So that's a great question. There's two ways to answer it. I can give you the technical answer about how the model works and performance measures and so on. But for the larger answer is that it's an irrelevant question to ask, because I think the more important thing is what it does. And that's what I would like to share with our audience today, is that typically palliative care is in a very pull model.
And can you define that?
Palliative care is the use of medical treatments to improve comfort of care, not necessarily at the end of life. It could be applied when you're, say, having a bone marrow transplantation. And typically it's invoked when your treating physician recognizes and asks a palliative care physician to get involved. And given the hospital of our size and most other large hospitals, they'll have a palliative care service line about 80 or 100 patients get admitted to our hospital. If the bedside clinician does not invoke a consult, you don't get to see palliative care. And for a palliative care physician to review all the 100 people who got admitted and make a determination should I or should not help is too much work.
So there's a matchmaking problem.
So the model, what it does is it ranks people. Everybody who gets admitted, it sorts them by their probability of dying in the next 3 to 12 months with the explicit understanding that that is a surrogate for the chance that they might benefit from a palliative care physician talking to them.
Because you needed to figure out some way to prioritize.
Exactly.
And so the palliative care physician can come in the morning and say, who are the people I should most urgently potentially assess?
Exactly. So medicine in a nutshell is who do I call today problem. Mm-hmm. There's 100 people to take action on, and it would take you 5 minutes to review a chart, which is 500 minutes you don't have. And so if you can have an algorithm reduce the workload, the rummaging workload, and say, look at these 10 people or these 15 people, the 5 you need to see are in them. That's how we use the technology.
Great. So now in the system that you kind of described, the old system, the primary current caregivers would realize that there was a need to bring in a consultation. How have you changed that dynamic? So you introduced this new tool. Who does it go to? Does it generate a, you should go see this patient, or does it generate a, please talk to this physician to find out if they're comfortable with you seeing this patient? How is the best way to deploy this capability?
That's another great question. So instead of nudging the bedside clinician, the predictions here go to the palliative care service team.
Okay.
And they are the ones who make a determination that given the situation of the patient, given the treating team, is it worth to call up and follow up with that individual? And many times it'll also involve a quick 10-minute conversation with the treating physician to say, is it worth chatting with this patient? What is your opinion? So there's 2 humans in the loop before a patient gets communicated with.
Great. And then there is a sense that then the treating physician, by that 10-minute conversation, doesn't feel like that somebody's done an end run around their ability to look at the big picture for the patient.
Yeah, exactly.
So getting a little bit into technology, what kind of data do you use to make these predictions? Does it need to be perfect, or does it need to be just good enough?
I would say it's more on the good enough side. The goal is not to get the exact probability correct, or to predict you're going to die on so-and-so date.
And I would guess you would never say that to a patient.
Exactly.
It's not a good way to build
trust.
An alliance, yes.
So, but the point is that if you have, and we've done a lot of analysis on this, looking at, how much of prior data do you need? Do you need 1 year? Do you need 2 years? Or do you need, 8 visits minimum? And what kinds of data, ICD-9 codes, lab test results, and so on. And by and large, if you have about a year of data and more than 8 visits, it's good enough to get a reasonable ranking.
This is The Future of Everything. I'm Russ Altman. I'm speaking with Nigam Shah about the use of data to improve medical decision-making. And you said that now in the case of this palliative care decision, about a year worth of data, both maybe outpatient as well as inpatient. And then you look at the things like the types of medications they're on, the types of diagnoses they have. Is that what your machine learner is actually kind of mining from?
It looks at a lot of things. So, the feature space is in the 50,000 range. And
so when you say feature space, you mean the list of the types of information that you can use?
The characteristics about the patient. So the number of codes they have is kind of an obvious one. Their age, how long have they been seeing doctors, and so on. Okay. And then there are features that we can manufacture, such as the number of specialist visits you had in the first quarter, second quarter, third quarter, and is the rate of that going up or going down?
Right. So the acceleration of your need for medical care.
Exactly.
Because we've all heard about the end of life is when a lot of the expenses occur, and it's because you start seeing more and more doctors, more and more procedures. So that raises the sensitive issue about, can we distinguish people who have a disease that just needs a lot of attention and focus versus the ones who are the best candidates for palliative care? They're both sick. Mm-hmm. One of them we might expect to get better with all of this intervention. Another one we might say, you know what, all this intervention is a proxy for a game that we're ultimately going to lose, and maybe even pretty soon. How do you handle those tensions?
So it's basically supervised learning. We looked at 2 million patients worth of data.
What does supervised learning mean?
And so the idea there is you look at examples of people having certain characteristics and then what happened to them.
Okay.
And in our 2 million or so patients that we have in the past, both situations happen, as in somebody's really sick. It's a young person with a trauma and lots of operations, but
they get better.
And they get better. And so the computer learns the different interactions, the combinations of patterns that are indicative of someone who is actually in real trouble versus somebody who's in a medical state but will eventually recover.
I see. So I think, to paraphrase, I think what you just said, you can look at the old data and look at people who did get palliative care and look at people who did get better and make sure that you train the computer to distinguish to its best capability those different groups.
Exactly. And so as a very crude high-level analogy, if you show 1 million pictures of cats, you can train a computer to recognize cats. And by giving enough examples, we can train the computer to distinguish these two situations. It's not perfect, and therefore we have the two humans in the loop.
So I'm sure people, when they learn about this, ask you about the issue of privacy. Was my data used to inform your models? And did you ever ask me, or should you have asked me? In fact, I am a patient at the hospital that I think you analyzed the data at. So what's the issue with respect to getting access that is secure and useful for these kinds of very meritorious projects?
So there's 3 ways I can answer that question. If you go to any teaching hospital, you've already given permission to use your data for research.
When you walk in the door.
When you walk
it's
in the
one of
door.
those 20 papers that you've signed.
Correct. Not everybody reads those. I certainly didn't read them.
Especially when I have a medical problem that needs to be addressed.
Exactly. You just sign and move on. So that's the technical answer. Not very satisfying.
Which would be, you sign something, we can use your data.
Correct. The second answer is that this is about improving quality of care. And under our current legal system, use of data to improve quality of care is the core to a hospital's mission, and therefore is permissible use. So that's the second argument. And
that is to say, there's a difference between quality of care work and pure research.
Correct.
Whereas if it was a research study, you might have to get an informed consent. We're doing some research on you. We'd like you to approve this. But there's kind of an exception. Please tell me if I'm getting this right. There's an exception in the case where you're just trying to improve processes that are already in place.
It's not even an exception. So if you're in the hospital, I don't need people's permission to do things that make your life better.
Right.
I mean, that is why you come to the
And that's
hospital.
what you would want as a patient. You wouldn't
Exactly.
want there to be huge barriers to improving the quality.
Correct. Now, the third one is actually the one that I really want to share with the audience, is that everybody wants better care based on similar patients like themselves. Mm-hmm. But if we don't share our own data, then what right would you have to get better care based on similar patients? So it's like the commons. You get to use it if you contribute.
That is a huge issue, which we'll talk about in a moment. This is The Future of Everything. I'm Russ Altman. I'm speaking with Nigam Shah about the use of data to improve medical care, issues of privacy and access. And you just made this very important point, which, in my experience, varies greatly over different cultures, literally cultures around the globe. There are places where the idea of all for one, one for all, make my data available, is an ethic, and there's relatively few barriers to aggregating medical data and using it for discovery and for what they sometimes call secondary uses. It's not the main use is to support the physician, clinician in making decisions. The secondary uses are the kinds of things you're doing to discover new knowledge. There are other cultures where there is not that same instinct to share. What determines whether or not there is a big ethic for sharing data in your third examples versus not? What have you learned about that? So
in the U.S. particularly, there's a lot of confusion around this topic. I like to quote Ruth Faden, who's a bioethicist, and who makes this argument very compellingly that if we want the learning health system, then unless you contribute your data, what right do you have to benefit from other people's data? It's a very simple, logical, moral argument.
And it goes right to core principles of justice and fairness.
Exactly. On the other hand, most people in the audience might be shocked that your health data is today being bought and sold without your permission by lots of commercial entities.
And why is that happening? And is it a good thing? Is it enabling good things to happen, or should we be worried?
So far, I haven't seen use cases that would cause me to fret and worry. but there's a group at Harvard that in 2013 made a graph or a map of when you go to the hospital, how many other places do those data go to? And legally required, as in not, somebody's breaking the law or doing this under the table.
So this is the normal flow of medical information.
This is a normal flow of medical information, and it is shocking how much is available for purchase. I think the state of California will share with you all emergency department visit information for like $50 or less.
So the state even sells this data.
Correct.
To private industrial.
To anybody. Any citizen can get it.
Huh.
It's de-identified. It doesn't tell you who the person is. But a lot of data is being bought and sold every day in the legal way by governments.
And is there a sense that this creates opportunity for discovery, or is there a sense that there may be more risk than people appreciate?
I would say this is an underutilized opportunity. These data have been available for many, many years. So far, nothing bad has happened. They're all de-identified. They're not sharing your name and address and phone numbers. And as a society, I think healthcare is actually way far behind in assessing global trends, population level needs, for policy decisions, for building facilities and so on. So I think it's an underutilized resource, in fact.
Fascinating. So I know that you've also worked in the sources and concerns about bias in medical data. And this is a big conversation that's important to have, because when we build these machine learning algorithms, so everybody or many people have heard about these high-profile cases where Facebook or other like online net internet companies have tried to make predictions, and they turned out to basically make racist predictions, that they seem to be embodying a racism that they certainly didn't put in on purpose, but which seemed to reflect some internal features of the data that they used to build these AIs. And the problem has arisen that this might happen in medical systems. And I think you've spent some attention thinking about this. What is the problem, and what are the potential solutions for bias in these AI for medicine applications?
Right. So there's two ways to think about this problem. This kind of bias has already existed for decades. So, for example, the Framingham Heart study that led to the ASCVD risk equation for cardiac problems,
which we use to assess
on a daily basis
whether a patient's at risk for a heart attack, basically.
Correct. Those are biased for Asians and African Americans.
We know that. Biased for, what does that mean?
Mean the probability of risk that they give you is either over or underestimated depending on your ethnicity.
But it's more accurate for European descent people.
Correct. We already know that. And doctors correct for that. We can do the same for these kinds of fancier models.
This is The Future of Everything. I'm Russ Altman. More with Nigam Shah, especially about the topic of bias in medical records, next on SiriusXM Insight 121.
From the campus of Stanford University.
People are worried about data. They're worried about their privacy and their security. They should be. We need secure systems.
This is the future of everything.
But we can't have a system that closes that data off. It is too rich of a source of inspiration, innovation, and discovery for new things in medicine.
With your host, Russ Altman.
Welcome back to The Future of Everything. I'm Russ Altman. I'm speaking with Nigam Shah about the uses of data. And we were just starting a discussion of bias and how the bias that's present in the data can basically manifest itself in bias in the performance of algorithms. Can you give us some examples of where bias pops up and just put a little meat on that idea?
Yeah. So the main issue main reason such biases arise is that if you have not collected data on certain kinds of individuals, and let's say just go back to those risk equations about cardiac risk that we're talking about. If you've only collected data from Caucasian descent individuals, and then we use those same that equation to estimate the risk for somebody of Asian descent or African American descent, you get a number that is either over or underestimating the risk.
Because it didn't include those types of people in the original.
Correct. It's basically, if you've never seen an example like that before, then you're going to make a mistake in guessing the outcome for them, is sort of the gist of the matter.
Okay.
And there's two broad categories of ways around this. One is to just collect data on those individuals. It's hard, takes a while, but that's the long-term solution to this. And this,
Let me just highlight that. This is simply conducting clinical trials and medical research that represents all groups in reasonable numbers so that you'll have the core data so that you don't come up with biased AI systems.
correct. So again, for the audience, a third of humanity is either Indian or Chinese.
So a cardiovascular risk that doesn't do well on them is really not serving the globe very well.
Correct. And so till that long-term solution happens, there are certain algorithmic tricks that can be used. And to give an intuition around that, you can say, well, we don't have good representation, but we have some. Can we upsample or look at their data a little bit more, give that more weight?
A little bit more weight, even though it's a smaller numbers, we're going to pretend like that's a more important group to do well on.
Correct. The other broad
Not just pretend, it's actually true.
and the other category of things can be done on the algorithms front is to say that, I know that there's 3 subgroups in the data, and I know 2 of them are really not that well represented. But as you learn the model, I'm going to put a constraint that try a whole bunch of other tricks, but make sure that the accuracy is equal for all the 3 groups.
So you can tell the AI algorithm as you're creating it that you value equal performance
Correct.
over optimal performance on average.
Correct.
Because if and tell me if I'm right, but if you insist on optimal performance, it might say, well, there's this group of European people who I can really do great on. I'm going to do great on them because the numbers for these other groups are smaller, so my average performance will be higher. You can tell it, don't do that.
Don't do that. Exactly. So that the word used for that is to enforce either demographic parity or equality of odds. They're related but different notions. So equality of odds is sort of the most useful one in the sense that for all subgroups, when I say you're going to have an event or not have the event, I want the odds to be equally correct for all subgroups.
Yes.
And you can say how much of a hit you're willing to take on the performance of the most well-performing group. Because that's also a trade-off. You don't want to...
No, this is an ethical... This quickly gets into ethics because what you're telling, for example, your European descent person is, I could have built a model that would work better for you, but we believe that society has an interest in a more fair algorithm. That sounds great in general, but when you say that to an individual patient who might have gotten better performance from another algorithm, that becomes an ethical issue. So how do you navigate through that?
So I actually take a more provocative stance and say, how is it ethical to that majority subgroup that we're decreasing their performance in the interest of increasing fairness for others?
Right. So there's a fundamental injustice that you would try to invoke.
Exactly. And so there's ways around that. I mean, you can trade off how much of a hit you're willing to take versus the gain you get in the performance for the smaller subgroups. If you're losing 1 point performance, but you're getting 10 points improvement in the smaller subgroups, that's most people will take those kinds of deals. And ultimately, it boils down to that change in performance, that 1% or 2%. Is it really leading to any net reclassification in the decision that's made?
Right.
So I'll happily take a 5-point reduction in performance if there's not net reclassification, but it improves the net reclassification for the minority groups.
This is the future of everything. I'm Russ Altman speaking with Nigam Shah about big data, bias. Have these methods been used to actually fix some of these biased algorithms? Are there examples that we can point to?
Yes and no. There's a few. So one of our fellow faculty here, Sanjay Basu, took the most widely used cardiovascular risk equations and retrained them on newer data so that they would become more accurate for the African American subpopulation.
Now, just to clarify, did he come up with 2 or 3 new equations, or did he still look for a single equation that just performed better over all groups?
In this case, they looked at the existing single equation and modified the weights of the different characteristics in that equation to make it perform better.
So this uses some of those techniques that you just mentioned previously for weighting and...
Literally, they just weighted, because these Framingham risk equations were built many decades ago. Over time, better data has accumulated. No one went back and retrained those equations, and they just did that. And it affects the care of an estimated 40 million people.
And it worked in terms of improving the performance.
Correct. For one subgroup, it worked. The other one, no harm done, didn't work.
So that is good news because it gives us a way forward, even when we have imbalanced data and we don't have all groups represented. Does the field appreciate this? And are the companies and the academics, is everybody who needs to be aware of these bias and these bias reduction techniques, are they starting to mobilize and use them? Because I could imagine there might be a dissemination problem in getting this word out. And we saw that because we saw all of these internet companies really releasing products where it appears that they had never thought of this problem.
So now there's definitely a lot of awareness. Is everybody on the same page? Probably not yet. There are people in the computer science and the core AI communities that are thinking deeply about algorithmic solutions to fairness. There are ethicists thinking about what should we define fairness as in this context. And then there are people like the informatics professionals and the doctors who are trying to apply this in practice and say, what can we use from the computer science community that is good enough to change care today?
Great. So now as you look at this, one of the things you've said a couple of times is as you go forward, one of the ways a simple way to mitigate this bias is to make sure that you have balanced clinical studies and balanced patient selection so that you have plenty of data for all the different groups. As you sit looking at big data that you use for your work, what are the new sources that you're most excited about? Are there new data streams that you feel when we get that, it's really going to help? What's getting you excited these days?
So I'm pretty excited about patient-generated and patient-reported content. The medical establishments, so to speak, kind of still suspicious about the quality of those data. But in a real study, we've used data from large patient forums, about 1 million people blogging about their treatment experiences and their care providers chiming in and so on, to discover new adverse events of an anti-cancer drug. It's a cutaneous adverse event, and it goes to the dermatologist. And the dermatologist and the oncologist typically never connect. But for the patient, it's the same individual. And so these kinds of data sets, broadly called social, maybe something coming out of your wearable.
Often on social media, that's why they would call it social.
Will be new data streams that we as a community have to figure out the right way to use them. But those are giving us signals that don't exist in healthcare. And if you think of a patient's timeline, very few percentage of your time is spent in the healthcare system. The majority of life happens outside.
Thankfully.
And we need to thankfully, exactly. And we need to collect data on that healthy side of life and not just the sick side of life.
So, and I'm sure that this rings true for patients who, when they have a disorder or a disease, are immersed in it and they Google about it, they learn about it, and they often want to have a voice. And so it must be good news. I'm imagining that patient advocacy groups love the idea that the patient voice can now become part of the formal research establishment.
And even on the research side, the PCORI, the Patient-Centered Outcome Research Institute, funds, I think, 15 or 18 patient-powered research networks to try to get a handle on the thinking around what is the right way to use these data to benefit the care of individuals.
Thank you for listening to The Future of Everything. I'm Russ Altman. If you missed any of this episode, listen anytime on demand with the SiriusXM app.